It's, I would say, moderate difficulty. What we see in the real life is that candidates usually struggle most with computer-based scenario number 3, which is biochemistry. Because you will be more tired as the day progresses. That's why we've deliberately changed the order, and CBA1 radiology will be in the end of this course, okay? I am here to, and also we dim the light so you can fall asleep easily if you want to. Okay, let's crack on. The blood station is covered in 2 different talks. I will introduce you to how to do these cases and then go through the most difficult part, which is advanced acid base. And then Armand Girbes hopefully will come and talk about approach to difficult cases of mineral disbalances, and also diseases with a pattern, how you recognize hypothyroidism, for instance, from the blood, and also will summarize the topic for us. Very briefly, so usually there are only 8 cases per 12 minutes for bloods, okay? Whilst there is a 12 pictures, 10 curves, only there are 8 laboratory scenarios, which gives you a decent time to think about it. It's roughly 90 seconds, which is quite a long time. So usually the cases are arranged, or the order is with increasing difficulty. So you start with something which is warm up, you can just easily spot it and save some time. And then as you progress, the cases become more and more challenging. Indeed, the order is a judgment of the exam creator rather than candidate. So it's not necessarily your subjective impression, but what the examiners think there should be an increasing difficulty, which means for you in practical life, if you save some time in the very beginning, you can use it and think for a long time in the end, okay? Also, it's pattern recognition, so probably 90 seconds is enough, but not really long enough to make complicated calculations. I will come to this. The vignette. The vignette is of crucial importance, so you, as any CBAs, will be given a brief introduction to the case, and then a laboratory picture, or the blood results in a unified format. I'll come to this. And there are usually 1 or 2 questions which can be either on diagnosis or even more often on the management of the case. So introduction as a start, 24-year-old patient brought to emergency department due to confusion. Then on the left upper corner there are ions and organ function markers when relevant. Blood gases on the right top corner. Left bottom corner is also important because this is where usually is a blood result from urine or something you don't normally send, like CD count, and it can be a key to the diagnosis, so do not overlook this corner. And there is a question, 1 or 2 questions. So this is an example of probably the first case. You can see profound metabolic acidosis with positive hyperglycemia and positive ketone, so probably you spot very quickly the diagnosis of DKA, and that's where the points are. You just have to make the diagnosis of DKA and suggest crystalloids and insulin as the key to treatment. Please be aware that there is no cheap points. You know, if you just name the laboratory abnormality, this is not going to win you any points. What you need to do is to synthesize the information from the vignette and from the laboratory picture and answer the question as is asked. So it is advised to think aloud, but it's naming the abnormality is not going to win you any point whatsoever. So reading the vignette in biochemical cases is particularly important because there may be many blood results and most of them appear red, okay? So they are pathologic and the time is limited. So what you need to do really is to have the question in your mind before you start reading the bloods. So my advice is to, before you even put your eye on the blood results, just read the vignette first and try to think about what you are looking for. There are even some cases which we had to remove from the EDIC question database because the vignette was so hintful that it was possible to make the diagnosis even without seeing the blood result. It was like an example is here, elderly man after cabbage with multiple thrombotic episodes and dropping platelets. Wow, you don't need to see any more blood. It's just heparin-induced thrombocytopenia, isn't it? So this was remain. But if you have 18 years old with vomiting and confusion, right? Just stop this 5 seconds and think what it could be. Is, well, overdose, common thing are common. Can she have cerebral central nervous system infection? Is it a TKA? Is it something else? Okay. This one, 65 with hemoptysis, no chest pain or shortness of breath. So what we are looking for, hemoptysis. Why? So is there a coagulation abnormality? Can he have TB? So what are his inflammatory markers? Could it be lung tumor? SIADH. How is his sodium? And by this way, what is his kidney function? Because in case there is a derangement in kidney function, it could be a good pasture. So this is kind of the way how you should treat the vignette. Last example from this section, patient treated for preeclampsia. We had this case in the real exam, okay? So this was not, there is no cases from real exams, but some of them can be very similar. And this is an example which appeared a few years ago. And, well, the vignette will really tell you what's wrong. Previous 24 hours treated for preeclampsia, transferred to ICU with bradycardia and poor cough, okay? So the key to diagnosis, there are various derangements, but the key to diagnosis is in the vignette, okay? So the question is, what is your diagnosis and how do you confirm it? Any idea? Absolutely, yeah. The result is not there. So what you are really interested is the magnesium, which is not given. So then by synthesizing this, what is the treatment for preeclampsia? It's magnesium, and now we have bradycardia and poor cough. So the measurement of magnesium and hypermagnesemia are working diagnosis. And indeed, she may have respiratory acidosis due to muscle weakness, and due to preeclampsia, we can see the signs of AKI, which are supporting your main diagnosis, but you don't win any points from this. Okay, so this was just an introduction, and the composition of cases is, I would say, half and half in between difficult acid-base, because reading the blood slip with blood gases is the daily bread and butter of an intensivist, and the purpose of this part of the exam is just to figure out how good you are. Indeed, even though that there can be some easy warm-up blood gas, which is pretty obvious, this is not a medical student stuff. It's an advanced intensive care exam. So please expect that there could be some tricky cases, and I hope the rest of the lecture will help you to go through them, okay? This is a typical example of a difficult one. So 28-year-old alcoholic presents with 3 days of nausea and vomiting. He's confused, he's tachycardic, but otherwise his vital functions are stable. Abdomen is soft and non-tender. There are blood results here, including blood gases. Describe acid-base disorder and give possible causes, okay? So this is a real-life case, and we will go through this during our lecture. You may have noticed that blood gas looks perfectly normal, but there is a rule that sick people have sick values, and this is exactly when you should raise your eyebrow, because normal blood gas in a gentleman who is sick as a dog, it's probably something which requires attention. Unfortunately, the classical Danish model, which we are all taught to look at blood acid base according to, does not work always, okay? It's just historical thing which is indeed following the rule of chemistry, and it looks at essentially bicarbonate buffer system status when it just says that pH of the system of the blood is determined essentially by the ratio between the concentration of bicarbonate and PCO2, and according to the arrangement on one direction in one system or the other, the acid-base status is assessed. There is indeed some drawbacks to it. First of all is that simply by the law of chemistry, bicarbonate buffer system is inferred from the dissociation equation of carbonic acid. And in the early 50s, even these guys realized that the problem with looking at CO2 and bicarbonate as an independent respiratory and metabolic entities is not quite correct, because an abnormality, let's say acute rise in CO2, will shift the equation, okay? It shifts the equilibrium indeed, and thereby it can cause a rise. If you have a sudden rise in CO2, like in a suffocating patient, the bicarbonate would go up without anything happening on a metabolic side, just because of this equation. And that is why they came up with a solution which works, okay? They needed to separate it somehow and create a mental construct which would leave bicarbonate and CO2 independent to each other. And that's how how the concept of standard bicarbonate and base excess arisen. So you may have noticed that on the blood gas slip there are various abbreviations. So what is it really? If we go, first of all, what the blood gas machine measures is pH by an electrode and PCO2, okay? That's all the input. The rest is calculated from Henderson-Hasselbalch equation. So actual bicarbonate, abbreviated with A or ACT, depending on the machine, is the value which is calculated as from pH and CO2 which is measured. Indeed, this value is subjected to the influence of the shift of the equation, so it's CO2 dependent, and it's not really a measure of a metabolic component of the disorder. And that's why they came with the concept of so-called standard bicarbonate. And standard bicarbonate is a level of bicarbonate which would be if CO2 value would be corrected to exactly the middle of normal range. So departure of standard bicarbonate from the normal range will tell you about the metabolic component of the disorder cleared from any influences of any shifts of PCO2, okay? Because you have to still compare it with normal value, some people prefer to look at the base excess, which is indeed normally 0, and you can view it as a difference of standard bicarbonate measured in a patient from the middle of standard bicarbonate normal range. Because of the bufferation capacity differs, there could be a base excess calculated differently from whole blood and from the model of extracellular fluid. You can forget about this difference. It's not clinically significant. You can treat those base excess values. They differ only very slightly, okay? So this problem one is now solved. They've done it in the late 50s. They simply introduced the concept of standard bicarbonate or base excess to clear the numbers from the influence of shifts of CO2. That's all fine, but unfortunately, it's still not enough. Right. From the, did you get it so far? Yes. Good, brilliant. It's very simple stuff. The other thing is that looking at the acid base as the ratio between bicarbonate and CO2 allows us to introduce interesting and important concept of so-called compensation, which means if there is a primary disorder in one, either numerator or denominator, the other system can compensate. Okay, so it's very basic that the shifts of CO2, if it lasts long enough, can cause bicarbonate retention or excretion, thereby normalizing pH. On the other hand, metabolic disorders are compensated by either hyper or hypoventilation, thereby shifting pH back to normal range. So-called Boston School in America came with a set of 4 quite complicated equations which should solve the question, what is the primary disorder and what is the compensation? So they tried on behalf of mathematical analysis and empirical data, they tried to infer a set of equations which would show you what's the appropriateness of compensation for a given disorder. These equations are quite complicated, and it's my subjective opinion that they are not very useful in clinical practice, with one important exception. And this is the rule for appropriateness of respiratory compensation of metabolic acidosis, right? This equation will tell you what the PCO2 should be for any given bicarbonate level. And you can calculate it very easily from your head, because if you have bicarbonate in millimoles and divided it by 5 and at 1, you should get the appropriate PCO2 value for any given metabolic disorder. Look how it is important. I use one exceptional slide, right? All the cases you will see during these presentations are people who lived and are real. Some of them are still alive. This one is the only hypothetical case which is based on calculation, okay? So imagine a young girl who you see in an emergency department, and she is thought to have a profound DKA. She's a diabetic, she takes insulin, she drinks a lot, and she's a frequent flyer on your A&E, okay? And she comes with profound acidosis with bicarbonate of 7, okay? And there are 3 hypothetical scenarios which you look at. She can have 3 different levels of PCO2 and indeed different pH for this given bicarbonate. If you use the Boston rule, you can calculate that PCO2
for this given metabolic disorder should be 2.3, okay? But it isn't. Well, oh, in case A, right? Let's imagine situation A. PCO2, it's exactly as it should be. So what do? Well, it's simple. You just admit her to medical HDU and treat routinely DKA. No problem. But what if there is a situation B? pH 732, PCO2 1.3 kilopascals. Okay? This is by far lower than predicted as per Boston rule, which means that there is not only a metabolic acidosis, but also a respiratory alkalosis superponed on top of metabolic acidosis, okay? And this needs explanation, right? She simply can be anxious, hyperventilating. She can be in pain, indeed. But also she can be pregnant. This is a typical state which can induce respiratory alkalosis. And also it can be something else than DKA. She may have taken some salicylate. So this situation B should raise your eyebrow, and you should stop and think what is the explanation for the respiratory alkalosis, okay? Situation C, indeed, if you have PCO2 3.3, even though compared to normal range, it's still low, for the given metabolic state, it means CO2 retention. So it means that this girl is developing impeding respiratory failure, and I would like to have her on ITU because she may need intubation, which is, as you all know, extremely tricky in severe metabolic acidosis. Okay, so this is a practical application of Boston rule, and this is why you should remember it, and it can appear. Right, so if we come back to simple stuff like metabolic acidosis, this is one of the mental models which probably most of you have in your heads, and also it's a classical thing we teach medical students. Okay, so if there is a low level of bicarbonate, let's say standard bicarbonate, which defines metabolic acidosis, there must be an explanation for it. So either the chloride is high or the anion gap is high. So this defines two big families of metabolic problems, and we are all taught, okay, if there is a hyperchloremia, it means that the bicarbonate is lost, and the loss can be either via gastrointestinal tract, is there a pancreatic fistula, or whatever. It can be renal tubular acidosis, or the patient may have been given too much normal saline. That's how we think. And if it's an elevated anion gap, which normally is calculated as a sodium plus potassium minus bicarbonate and chloride, then elevation requires to look for an acid which is circulating there and explaining the elevation of anion gap. That's a simple stuff, but the thing is, and the problem with this approach, which essentially requires identify the disorder, then look for an anion gap, and according to whether it's high or normal, make the basic differential diagnosis into these two families, and assess the degree of compensation as per Boston rule. This will work in most of the cases, but not all of them. And I now want to look at those cases in which classical approach fail, and I want to demonstrate and introduce probably an alternative algorithm how to think about complex acid-base disorder. Problem with classical Danish approach is that if there are two disorders which correct each other, you cannot see them. And you have to think differently to find these complex diseases. That's why in late 70s and early 80s came Peter Stewart with his innovative approach of quantitative assessment of acid base, which is based on the rule of electroneutrality. Unfortunately for the clinical world, Peter Stewart and his followers were fascinated with emerging world of computers, and they were fascinated with equations, and it does not work for clinicians because we need something simple, something we can remember, something we can apply in the stressful situation. And the concept of electroneutrality was somehow discredited by its complexity. But I want to demonstrate now that the basic ideas are still there, are alive, and can immensely help us. And you will not see any single equation. I just will demonstrate the complex. The idea is simple, okay? The idea is that there is a law of electroneutrality which applies to all body fluids. It says that the sum of cations must always equal the sum of anions, at least in human beings. It's slightly different in electrical fish, but we won't go to this, right? And, well, without any further things, we will for now ignore small amounts of other cations like potassium, magnesium, and small amounts of strong acids, which normally circulate in our bloods like lactate and others. And we will look at the difference between saline and chloride. Once there is a sodium cation and chloride anion in the solution, they are there and they are 100% ionized. So they define a space which is called strong ion difference, okay? And this strong ion difference has to be filled with anions somehow. And if you look at this way, we have some circulating albumin and phosphate which bring about a negative charges. And you have a predefined concentration of albumin in your blood, and you can't quickly change it. And this defines the number of negative charges on them, right? And you can easily remember that 10 grams of albumin per liter contain 3 millimoles of negative charges, okay? So, some part of this space defined by the difference between sodium and chloride is occupied by negative charges on albumin and phosphate, because there is normally 40 grams per liter of albumin, which gives you 12 millimoles of negative charges, and some phosphate. This part, it usually takes 14 millimoles under normal circumstances, okay? And then there is a lot of CO2 dissolved in various forms in our blood, but the concentration of bicarbonate is always dependent on what is the difference between SID, strong ion difference, simply the gap between sodium and chloride, after subtraction of albumin, negative charges on albumin, and perhaps phosphate, okay? And this what defines acid-base disorder. Let me demonstrate it on our example. So, if you have a complex acid-base case, I propose you think about it this way, okay? Calculate in your head the difference between sodium and chloride, okay? And this will define the breadth of the gap between them, which is a given number, okay? Then you can infer what's the number of negative charges on albumin, okay? and the rest has to be filled with bicarbonate, right? And now there are a range of pathological situations which may arise, okay? Imagine you gave your patient 3 liters of normal saline, and sodium stayed constant at 140, and chloride went from 100 to 110, okay? What happens? The gap between sodium and chloride narrows, right? The albumin stays constant, okay? But given the law of electroneutrality, the smaller window between sodium and chloride with constant amount of negative charges on albumin unavoidably mean that the bicarbonate concentration is lower. And that's an explanation of saline-induced hyperchloremic acidosis, okay? And vice versa. If you lose chloride, the gap between sodium and chloride opens, and if the albumin stays constant, it has to be filled with bicarbonate, and this explains hypochlorhydremic alkalosis, okay? Let's think it another way. Let's assume that the gap between sodium and chloride is constant, okay? And now you come across a situation when albumin and bicarbonate together cannot explain this gap. Let's imagine the situation when albumin is normal and bicarbonate is very low with sodium and chloride normal gap. So it means that there must be something else circulating in this gap, not only albumin and bicarbonate, but also something else, which is usually strong acid, okay? And by doing so, this concept explains a few things which classical approach cannot explain. First of all, hypoalbuminemic alkalosis. Imagine a patient with sodium 140, chloride 100, gap between them normal, and albumin of 10 instead of 40 grams per liter. What do you expect his acid-base status to be? If there is instead of 12 millimoles of negative charges on albumin, you have now only 3. So, as per law of electroneutrality, the gap between sodium and chloride has to be filled with bicarbonate, and this explains hypoalbuminemic metabolic alkalosis. So, if you have a patient with albumin of 20 and base excess of +6, you are fine, because you have the explanation for base excess of +6, and there is no other problem, likely, okay? It also explains, as I've demonstrated, why hyperchlorhydemia causes acidosis. It causes acidosis because it narrows the gap between sodium and chloride, and because the number of negative charges on albumin is fixed, you have to compromise on bicarbonate. Easy, isn't it? Okay. There is also one thing, and because I can see understanding faces, we can introduce one more, even more complex thing, and that is, imagine a patient which develops insipidus and lose free water from the system, okay? And let's assume that his sodium goes from 140 to 160, okay? And chloride goes from 100 to 114, okay? And if you concentrate both sodium and chloride by the same percentage, what happens with the difference between them? It widens, okay? Because hence there is a higher baseline concentration of sodium than chloride. Removing free water from the system and concentrating both at the same percentage widens the gap. And this explains so-called concentrational alkalosis, okay? But that's usually not quantitatively significant, and we can ignore it for now. I'm just demonstrating how the principle of electroneutrality can help you to get deeper insight into disorders. Okay, let's come back to our case of a man, and you now try to think about it with your newly acquired knowledge, okay? So, vignette, what could be wrong with this? He's an alcoholic, 28 years old, tachycardic. So can he have GI bleed? Can he have liver failure? Can he have drunk something else than ethanol? Could it be ethylene glycol or other alcohols? Or is it just unrelated problem like gastroenteritis or food poisoning or non-diabetic ketoacidosis? So it's not very helpful in this case. So, but let's look at his ions, okay? So this is the normal blood gases, okay? But try to look at it from the perspective of what we just said, okay? Let's try to look first at the difference between sodium and chloride, okay? It's supposed to be 40, but now it's widened up to 62. Okay? What it would mean if everything else was normal, widening the gap between sodium and chloride by 22 millimoles would mean base excess of plus 22 and severe metabolic alkalosis. But it's not there. Why? Okay. Okay, so here we go. We don't know albumin level yet, but it's probably not higher than it should be. It's either normal or lower, okay? So we are now at this situation when strong ion difference, or the difference between sodium and chloride, is 62, but his bicarbonate is normal, okay? So we have already diagnosed severe hypochloridemic alkalosis by looking at the difference between sodium and chloride, but we still need to explain this, okay? So if the assumed or measured albumin together with bicarbonate does not fit into strong ion difference, into the difference between sodium and chloride, it means that there is a circulating acid, okay? We don't know what acid it is. Looking at the blood gases, we have got severe metabolic alkalosis together with severe metabolic acidosis. It's base excess plus 22 and minus 22 combined together to 0, okay? We don't know what the circulating anion is, but it could be lactate in case of liver failure, but it could be something else, okay? This would be the points, okay? So 5 points for recognizing two disorders going against each other, some smaller points for suggesting the causes. What it really was, this patient has a lactate level of 20, INR 3 bilirubin of 100, and liver function test in thousands, and it was acute on chronic liver failure, and he was refused by transplant center because of ongoing alcohol abuse, and he died 20 hours later. With this nice gas, okay? Right, so we now can proceed to the algorithms which you can use when you don't know in your clinical practice and perhaps in the exam as well. And this is to just think about what disorder it could be and look separately at the difference between chloride and sodium and whether it fits with charges on albumin together with bicarbonate. And if not, then this approach will give you an answer to opposite disorders correcting each other. I would strongly recommend you to do it in your next 10 patients on ITU. And once you learn the algorithms, it's very fast And it just changes in your mind into pattern recognition, right? And you will become instant in diagnosing the disorders. You learn it very quickly. You just train your system one. Well, I don't want to discourage you from, if you have already learned it, you can indeed use alternative approaches, which there is nothing wrong with them. They are just using slightly different approach, but the results are the same. One of them is to calculate albumin-corrected anion gap, okay? When you say, right, if there is in strong ion different space for bicarbonate and strong ions, I can just use an ion gap and only correct it for albumin. It works perfectly. You can also look at the chloride level after correcting it to normal free water content in the body and compare it with normal range. Works also perfectly well. It's up to you. Also, there are steward geeks with applications in their mobile phones who can just calculate classical strong ion gap. It's nothing wrong with this. It's just the way how you calculate it is the same, right? I don't want to bother. Okay, let's practice. I sometimes call it a blood gas of my life. That's the nicest one I have ever seen. So this was a girl, 23-year-old, and she was 14th week pregnant, and she just came to A&E for excessive vomiting. And in the hospital I worked when this lady came, there was a pathway for such patients, okay? Sending them to obstetric ward, rehydrating them, etc. But still, somebody said, well, that's not, she's just wired, okay? And called ITU resident, and the registrar came to me and said, Frankie, look at this blood gas. It's wired. She's so profoundly acidotic. I don't like it, right? And the question is, now, analyze components of acid-base disorder and give possible causes. What would you say to the registrar under these circumstances? And perhaps spend a few seconds and try to think it the new way, the way you just learned, okay? And don't forget about Boston. Okay, so what you can see here is a profound acidosis. There is no doubt about it, okay? And if you, I'll give you the gas slip just to make it more realistic. It's the same numbers essentially. So first of all, let's have a look onto compensation, okay? So Boston rule says that with this level of acidosis, she should have PCO2 of 2.6. But it's not the case. It's lower. So we have got respiratory alkalosis here, right? There is no doubt about it. So if you look at the sodium and chloride difference, this would tell you that it's only 24. So there is a hyperchloridemic acidosis. It's supposed to be 40, isn't it? Why is that? This was the very first gas. She hasn't had even a drop of normal saline at this stage. Can anybody integrate these two into one diagnosis so far? Explain respiratory alkalosis. Remember the vignette? Of course, yes, she's pregnant. right? And pregnancy induced a state of respiratory alkalosis for which there is a compensation, okay? And what is the compensation of respiratory alkalosis? Excreting bicarbonate and chloride goes up, right? So there is a background which we've just revealed of compensated respiratory alkalosis, right? But the hyperchloridemic acidosis, or the process, explains only 12 millimoles of base excess. Oh, sorry, 16, because it's supposed to be 40, isn't it? So there is still some space for circulating acid which is most likely ketones, okay, because she's vomiting and she came for ketosis of pregnancy. Ketone test was positive in her urine. So what we have now here is 3 disorders mixed together. She started, before she started vomiting, she was pregnant, having respiratory alkalosis, okay? And because she had respiratory alkalosis lasting longer time, she excreted some bicarbonate and developed something which is a compensation of respiratory alkalosis, but on the blood gas it looks like hyperchloridemic acidosis. And on top of it, she had some circulating ketones, okay? Roughly 10 millimoles per liter, as you can easily calculate, right? So these are 3 disorders together. It's a bit too difficult for EDIC 2, but nicely demonstrates the concept, okay? I took her to ITU because I did not want her to receive any normal saline, because as you can calculate, even she has got already hyperchloridemic with circulating ions, and rising her chloride would really make them to be in deep troubles soon. So, but she recovered very quickly. Okay, so I'll skip this one, sorry, because of lack of time, and come to take-home messages. You will have enough time to practice tomorrow during CBA exams. And I want to just to conclude with this slide, that if you start using electroneutrality and use our rule of thumb equations, it will help you to understand complex diseases. So in brief recapitulation, look at sodium and chloride difference. If it's far from 40, there is a hyperchloridemic acidosis or hypochloridemic alkalosis, regardless of bicarbonate level. Then look whether this gap is explained by albumin and properly filled with bicarbonate. If not, look for strong acid. In all cases of metabolic acidosis, look at calculate appropriate compensation by simple Boston rule, because there could be a superponed respiratory component which can help you further, as demonstrated in the obstetric case. That's all from my side, and thank you for your attention. Any questions?
Thank you, sir, for this highlight. But what is the problem if we are using the delta gap, calculating this part, the delta gap, changing that gap equal to the change of anion gap, the delta gap? It can explain the multiplicity of the acid-base disorders. Is it quite wrong?
So this gentleman, just for recapitulation, asked whether we should look at the difference between base excess and an ion gap, okay? There is a problem with this, because in case the albumin is low, okay? Let's assume, I'll give you an example. If you have, let's say, somebody with an ion gap of 21, which is +5, okay? and base excess of -5, okay, then you are all right, aren't you? It fits. It's explained. And what if albumin in this patient is 10? Then you are missing 9 millimoles of something else, okay? So this is, you know, looking at the difference between anion gap and normal range and base excess together will not help you to discriminate in cases of water shift balances or disturbances of albumin. Well, as I said, the classical approach in 95 cases in your clinical practice, it works, but you still may overlook some more complex ones. So that's why I'm suggesting a different way of thinking. Take it or leave it. So if there is no question, I think we deserve a break, don't we? So thank you.